We're going to get started. I'm waiting for the okay from the critically important AV people. Okay, good afternoon. I knew when we scheduled it in this room that we would not have enough seats, and I apologize. If the dean is here, maybe he can add an auditorium to his to-do list on in the new School of Public Health building that he's building. But we have at least made arrangements for people through the audiovisual wonders of the 21st century to stream this live, I believe. Mike, do you want to explain how people do that?
Hi. Sure. Thanks, Art. Yes, I'm Mike Eichberg, the Executive Director of the Center for Emerging and Neglected Diseases. And we are sponsoring the webcast today, which is available live. If you go to our, if you received an email about this from us, it'll have the link there. You can also get to it from our Facebook page. And by the end of the day, the link to the archived broadcast will be available on our website as well. So thank you all for coming.
I assumed when we scheduled this on the first day of the semester it would be a good way to get the academic year off to a good start. And clearly this is an important topic and an important public health event. So I'm not going to spend more than a minute or two introducing Don Francis. I asked him to send me his CV so I could fill in any gaps, but I actually know Don well enough to not need his CV, although I did have a few errors in my thinking. Don attended the University of California, Berkeley as an undergraduate, but apparently never got a degree. We'll forgive him for that. Don also went on to do medical school and to do a Doctor of Science in virology at Harvard. Don has had several careers in virology. He did about 20 years of work on hepatitis viruses, ran one of the very first trials of hepatitis B vaccine, showing that vaccine was safe and effective. He then had a distinguished career in HIV and AIDS and HIV prevention, and now has started his own nonprofit, which is primarily intended to get improved diagnostics and other important agents into the field in poor countries to deal with infectious diseases. So, Don, I want to thank you for coming, and I'll shut up.
Thank you, Art. Thank you for all squeezing in on floor and seats. What I want to do today is to give a kind of the background of Ebola, having had the wonderful experience of being drafted into the first outbreak. As Art mentioned, I was at CDC, but then after my 3 years in smallpox eradication around the world, I went back to Harvard. Actually, I should admit I went back to Harvard because my girlfriend at the time went there. By the time I got there for my doctorate, the girlfriend and I had split, so I ended up just doing my infectious disease and my doctorate. But I did my doctorate there in feline leukemia virus, which no one thought was worth anything because there was no retroviruses causing immunosuppression in humans. And so why did I do that? And that's, as Art mentioned, I ended up getting into hepatitis, and then obviously came Ebola, AIDS. And so the great circle happens. But in the midst of that, actually, CDC only sent me to Harvard for 2 years for my infectious disease and my master's in public health. But I wanted to do a laboratory stint, and so I started essentially working on my doctoral program, not having my third year approved. But when they called me and said that they needed somebody with intensive laboratory experience with dangerous viruses, recognizing I was working on feline leukemia virus in hoods, but after we finished in the hood, we just shake the stuff out on the side because there was no human infections. And I said, I don't do these dangerous viruses. Why me? Well, you were head of the smallpox program in Sudan, you speak some Arabic, and you work in dangerous viruses. So we've got this disease down there that we don't know what it is, and we need somebody to leave today to go. And then they told me we had as I'll show you, the first electron micrograph Fred Murphy had at CDC, showing it was a filovirus, and I'm saying, why me again? They said, well, because you can do all these things. And for some reason I said yes. And the next thing I know, I'm joining one of two teams. The CDC team was dealing with a parallel outbreak at the time in Zaire, and I went to to southern Sudan with a team that I'll show you was a WHO team. It was more than challenging, as you might imagine. So let me see how we're going to do this. Let me go back and do some of the epidemiologic aspects of Ebola, and then use the South Sudan example where we're trying to determine an unknown disease and how to deal with it, with the dangers that were obvious, and stay alive and understand the epidemiology and ultimately control it. And then deal with the discovery finally of the animal host, which we had no idea at the time, because if you can't imagine how many animals we trapped. Here you are in the south of Sudan trapping animals, and you assume they're infected, so you got to use all your high security suits out in the sun with no electricity, dissecting animals and throwing them into liquid nitrogen with hopes of ultimately getting them to a laboratory in the developing world, industrialized world. And then I want to talk about the preventive success, at least in one country in the past, and then get into the issue where we are today, which is an amazing challenge, very different than the previous, because here, instead of a blip and everyone running away and the disease coming down, now we have disease spread in 3 very difficult countries that have had real economic problems in the past, and so you have all the public health structures that don't exist that you need to make these things work, and then you're going to get into urban populations where you're going to have a hard time controlling them. So this is the bug. This is Fred Murphy's original picture. When I was off on the Sudan side, the CDC team and the Zaire side of that outbreak sent a specimen to CDC, they cultured it, and this is that famous picture you see of Ebola, this very strange looking worm-like virus. And then this is I don't know how you can all see this, but these are this is the initial Sudanese and Zaire outbreaks in 1976. And these are the outbreaks, one every year, every other year, up until 2012, where you see in this, I'll show you the map, this cross the sub-equatorial belt of tropical Africa, the various strains of the virus and how many cases there were. And you see that some of these are hundreds of cases and the others are a few. But if they're not discovered early, it is very contagious, as I'll get into, the healthcare workers, and that's where the large number of cases come from. So you see the variation there from one case, a single outbreak here and there, to 425 cases. This, interestingly, is a map of yellow fever, and that's exactly the bar across Central Africa, which is the same for Ebola, starting in do I have a pointer? It's okay, Art. That you see the initial outbreaks in Congo and in southern Sudan, and then we'll see the outbreaks spread across the continent. So this is where we were in 2008. The different size of these different colors of the different viruses, which just try to ignore. And the different colors are the size of the outbreaks. You can't see it, no, it's all right. Oh, works on the wall, but not on the screen. But this, if you see the green upper right there, 1976 was the outbreak that I'll describe in some detail. And the similar one in red to the left in Yambuku, Zaire, was the first those are the first 2 outbreaks of Ebola. That were discovered, as you might imagine, tragically. And then you've had these spreads that go on and on from there periodically. So let me deal with what it's like to walk into these situations and what you have to do to put the pieces together and what it looks like. This was a very small team. I'm the cameraman behind. David Simpson right in the John Jazz. Under the sign there was the head from the London School. Barney Heighton, the guy with a hat, was the animal walla. You need to get somebody who's going to deal with you're going to deal with an animal host and to catch all these animals safely. Babakir Al-Tayyir from the National Lab in Khartoum realized at that time Sudan was one country, and the South Sudan was just the province. And David Smith, who was the clinician trying to deal with how we're going to deal with these patients. And this is the team. Here I actually found this in my garage. If you'd like to touch it and pass it around. But this is the kind of stuff you have to wear in all of your both laboratory work and your patient work, and especially in the tropics where there's no air conditioning and minimal light. And it's interesting that picture just happens to have the animal trap in there, because we had to do the same things with the animals we had to do with the human specimens. You had to assume they're infected. So you have all this incredible pain in the butt stuff. You're dripping wet in the bush trying to dissect animals and human specimens. And then we had the only way to keep stuff cold, we had a massive thermos of liquid nitrogen, which was flown in. And interestingly, we had all hundreds and hundreds of infectious specimens in that liquid nitrogen. And we wondered how we were going to get it up to London. And we went to the pilot of British Air, and they tied it on a seat in the cockpit. And they were not really worried about the Ebola as much as they're worried about the liquid nitrogen. Because if it spills onto the hydraulics of an airplane, it will freeze the hydraulics. And so we really were, here we had this incredibly valuable specimens that needed to get to the lab straight away. And luckily, the pilot agreed to bolt it in the cockpit and get it up there. But these are the team, and interestingly, some of it, as I mentioned, with the catching the animals and stuff. And this, you can't see it, but it's in the Bulletin WHO in 1978, is the massive manuscript describing all of the findings of this thing, which was a huge endeavor of ours and the Sudanese government. It was a wonderful interaction, indeed, of trying to figure out what it was, first of all, and then what to do about it, ultimately. So this is the area there. This is Maridi, and Yambio are the Nzara, and it actually started here in Nzara, and I will show you that it started in a cotton factory. All the other cases you can always connect to another case, but I think it was 5 people in this one room in a cotton factory that had no other connections whatsoever. And we didn't know what, but something about aerosolizing the cotton, which ultimately was bat urine, I'm sure, in the cotton, that ultimately caused the outbreak there. And that's different than you see elsewhere, because here we had the actual source, and we had specimens and all this stuff ultimately to prove it. But getting here is unbelievable. This is Juba. It was the capital of southern Sudan. This was all quarantined, so you couldn't get in or out. Once you got in, you couldn't get out. CDC sent me on this outbreak for 2 weeks. I worked in the outbreak for about a month and a half, 2 months, and wanted to come home. We were done, and the world then put us in quarantine for 2 weeks. So we were in quarantine in Juba for 2 weeks, but by that time, the German government was wonderful. They gave us an airplane. And so every morning we would leave quarantine, get in the airplane, fly back, and finish our investigations in the epidemic, and then fly back to quarantine. And then the rest of the world had no idea that that was actually happening. And ultimately, they said goodbye, and we flew home. So this is what it looks like. This is rolling low jungle way down in the south of Sudan. This would be the highway. It's dirt. We left Juba, I think, at about 3 o'clock in the afternoon and arrived there about 1 o'clock in the morning. Our WHO driver gave up, and I ended up driving the second half because it's incredibly tough roads with rain. It was a rainy time of the season, so we had mud and slides, so it took us hours and hours to get out there. And then you come into this little village out in the middle of the bush, and the hospital is actually the major part of the town that was a district capital, and that's where the Ebola came in. And interestingly, it was started down in Nzara in that cotton factory that I'll show you, and then spread through the hospitalization of people, and then it's classic Ebola. The next thing you do is the hospital staff gets infected. So the secretion, especially the blood of these patients, has 5, 6, 7 logs of virus in it, and you don't have good isolation procedures. And it's classic. Every time it comes in, Somebody gets sick and gets into a healthcare facility, and the next thing is the healthcare facility, and then all the doctors and nurses take care of the people from the healthcare facility, and then they get it, and it just keeps going and going. I'll show you the data. But it's very rural. That's this town, and you drive for hours before you see another town anywhere, so it's very, very isolated. There was one generator in town with a connected to the telegraph, so it was our only communication at that time to the outside world. What we didn't know is when we were sending it to Khartoum, the telephone line went to Juba, but then was broken from Juba to Khartoum, so they put it on the airplane. So we wondered why it would take so long to get some word back from Geneva on our communications, but it was because it was going essentially by road. And this, I put from the original report here, just to show you what it looked like in the old days. We had plenty of time for the quarantine to type all of our reports. And so this was actually the original report. And Zara at the top is the source in this cotton factory, and there were 67 cases, really no hospital there at all, so they were not hospital associated. They were acquired mostly with the home, and then they had this wonderful 21% unknown. These are the people who got it in the cotton factory and were the source of infection in the first place. And then one wealthy person, a businessman, that I'll show you his. Did I see John Jazz already? Let me go back and see. Yes, this is, the businessman was the owner of, was the owner of this nightclub whorehouse, and that was the extent, that was the entrance to it. And he ended up with, because he had resources, being referred up to the hospital in Maridi. And then this is the hospital. The hospital is on the right, which was essentially closed, and we built this hospital here on the left, which are adobe, mud, female and male wards with grass covers and a security gate on the outside, and it was all quarantined. And anyone with fever in that area, we had fever surveillance in town, and were put into the quarantine and remained there until they either died or left. And indeed, at the side of one of those buildings is where I did the post-mortem, which was probably the most dangerous thing you do besides the lab work there. And to do a post-mortem, you don't have a table or anything, you're doing it on the ground. And I was cutting this poor fellow up. And by the way, it's such a horrendous infection that when I cut his liver, it was like a water balloon, and it just fell apart. It was just totally gone. But we took those specimens, and while taking all these various specimens for the post, it started to rain. And then you start seeing your skin visibly coming through your gown, and you've got blood right up next to that. And the danger, that was really stupid. I should not be doing a post-mortem on the ground. And after I finished, I said, I'm not going to do that again. So, we could have gone inside the hospital and done it. But okay, the clinical picture, to give you an idea. If you just look at the top half of this, you see the severity of this disease, that obviously fever and severe headache, but it's funny, you got this chest pain and diarrhea and vomiting. It's a really severe a viral infection as you can imagine, where these people are literally out of it. And for example, unfortunately, Dr. Bowen at Porton Down Laboratory in England, the recipient of all of our specimens, stuck himself through a glove and came down with Ebola in England. And luckily he survived, but I talked to him afterwards what it was like, and really after about day 2 he didn't remember anything. It's such a bad disease, incredibly sick. And it's interesting, a couple of it's so severe in terms of, you don't see the rash too much on the African skin, but there's a large rash that comes out, and it desquamates if they recover. And I saw several patients, the desquamation on the feet was so bad that the entire cast of skin from the foot came off, including the nails. And you just had this little baby foot coming out with baby skin, and there was nothing. It's like an immense toxicity, like a sunburn of immense proportion, but in all the organs of the body. And then there is a hemorrhagic, some hemorrhage you see very common in subconjunctival, but some of the people, especially the severe ones, will be bleeding from all orifices. And that blood probably has, I don't know, 5, 6 logs of virus in it, so it's very dangerous for the healthcare workers. This is just a picture I made from the original data we had on these patients of what it goes with time. This is about 14 days. It's about a 7 to 14 day incubation period up front, and then you have 2 weeks of disease that's severe, and you either live or you die. And only even now, there's some of these, in this last outbreak, there's some interesting therapeutics, but usually it's just supportive, makes a huge difference with supportive fluids to keep them alive. But you can see the subconjunctival hemorrhages here, and the toxicity is huge. And then the town becomes just replete. This was the wonderful graves they had in southern Sudan. They were everywhere after this. And there's the next one, which is interesting. I don't know if you can see it. Oh, you can't. But this is a green hospital negligee of one of the nurses that died. And then what we did, fortunately, these remarkable group of people, this woman, these 2 men, and this fellow are all hospital staff who had Ebola and survived. And we even though they lost about 20% of their body weight and were beat up, we asked them to go into the ward and take care of patients because nobody else was willing to do it because of everyone at this point, all the cases were secondary infections in the hospital. And so they learned that we don't want to take care of these, but now they were their colleagues from the hospital, and these folks were good enough to go back and staff the inside of the hospital. And then one of my jobs there as the epidemiologist was to figure out how it was transmitted. I mentioned before that this was the cotton room at the cotton factory down in Nzara, which is piled with cotton when it's usually working, and cotton dust was everywhere. So it was probably either the ingestion or aspiration of urine, probably bat urine, but it could be any other animal that got it from the bats originally, that contaminated that aerosol and gave the first patients. But it would have died out in Nzara. Ebola usually dies out because it's so severe and recognizable, and people go away. They just run away from it. And that's why the outbreak usually dies. What happens in this case, as I mentioned with Johnny Jazz, was it got to the hospital. And if it stays out of the hospital, they usually just burn themselves out because it's such a bad, fast-moving disease. But in this case, it got to a hospital, and the results are horrific. So, as you see, in the beginning in Nzara, there was essentially no one in the hospital. There were 2 people because the hospital was a room like this with no facilities. And then it came to Maridi with 203 cases in the hospital there, and half of them were hospital employees. And the other half were people in the homes who had taken care of the patient. So it was the nursing of the patient, or in one case, there was one nurse at the hospital who got it from the doctor who was infected and got it sexually. So if any close contact occurs, but rarely. Most people with fever are not out screwing the nurses, but he was, and they both died. So in total, there were almost 300 cases in this one outbreak. This is very important here because we looked at a whole group of people and what kind of contact they had with patients that allowed transmission to occur. And in households, there was a quarter of the people who literally, adults who touched the patient and nursed the patient in some way would get infected. And then if they were actually nurses, it was 80% of them actually got infected. But look at this bottom line. This is right out of the report. This requirement for close contact explains the lack of cases in children who, although sleeping in the same room as Ebola patients, there were no children in this outbreak that got disease, even though they're just little huts, and they were still staying the same. It was the literal contact of infected body fluids that transmits. Okay, so this is the same slide as before, showing the band across Central Africa, and then this is the nice studies that was recently done and reported in Nature, which these little guys are the primary carrier of the virus and are apparently quite asymptomatic and hanging upside down in the trees and ultimately infecting some other animal, be it a human animal or a smaller. There's little deer that get it, and any of the animals that would be used for food, and if they are sick and slowed down, are more likely to be caught, and therefore then the human would slaughter them without gloves, and then ultimately get infected. So the epidemiology is well known now. Natural host of the bats, and bush meat, the wild meat that is the downstream from the bats, and then the humans get it from butchering. So what do you do? I think the first thing that's done, as I mentioned before, is to run away, and that probably is, there's probably other outbreaks of Ebola that have occurred, and people just stay away from them. Once the wife or the caregiver gets sick in a house, then if it's in a rural village, they'll just stay away. The basic quarantine in the worst way, or isolation. But as it gets more and more into a system, then there is at least one country evidence of a reasonable response. And I'm going to say it's a reasonable response in Uganda, only to compare it what's going out right now in West Africa, where it's a disaster. And that really is a function of the social structure of the country that can deal with an epidemic like this in a way that is reasonable. So that from Uganda's side, you'll see that it takes practice, it takes resources, it's expensive, and it requires an effective public health structure to deliver it, and really in the middle of an outbreak requires international help, because these can be, even the isolation clothing alone and stuff is expensive, not to mention all the rest of the things associated with it. So this just to show that if you look at the country up at the top, you see Uganda, Uganda, Uganda. There's a half a dozen Uganda outbreaks here, and I think it's quite remarkable what they've done. So they had the usual several hundred cases in the first outbreak. I'm sure it was chaos. 7 years later, they got another one with 150. And now the US government and others started putting money into these things and training. And now there were three small outbreaks in 2012 with very small numbers of cases. So that's what you can do with Ebola, even in a hospital structure. If you're using reasonable precautions, it will not spread. Now, if any slips though, any slip of, if you did it in a hot lab in UK with a needle, you can see that it doesn't take much of a slip to break through. But if you're really careful and don't have accidents, it is preventable. So now let's get to what we're really interested in today. This is the map of the distribution, interestingly, of outbreaks, and I think really importantly, the range of these bats across the globe. But the outbreaks, remember, you saw the outbreaks here before, and now look at that left-hand side of the Horn in Africa, and you will see that now you have 3 countries in Western Africa that have been newly infected. And you have the star in Lagos, Nigeria, which was a Nigerian citizen working in that part of the world, got sick and went to Lagos Hospital. And this is what we are as of last week. It is, somewhere in the neighborhood of this morning, 3,012 cases, I think. So you saw before that the total number of cases, I think, in the world was 2,500 or something like that, in all the outbreaks in the decades since we had the first outbreak in '71. Now we have probably doubled that almost with the outbreak going on now. And it is in Guinea, Liberia, and Sierra Leone, with the small export into a hospital in Lagos. And these are really difficult economies, all because of human management errors or misery. that Guinea was in had a 50-year dictatorship, had finally had elections in 2010, but it has the fewest hospital beds per capita of any country in the world. I mean, it is truly a basket case of proportion. Liberia, again, close to that with one doctor per 71,000 people. And the civil war in Liberia really involved all of these, both Sierra Leone and Liberia, and indeed in Guinea, with Sierra Leone with the lowest life expectancy in the world, caught in the middle of this civil war. And my fear here, and we're seeing it already, is that you saw the pictures of southern Sudan. That is not an urban area. It was a very rural area, really structured in terms of government. And when we set up quarantine facilities and scanned the population for fevers every day and disease and put them into a quarantine facility, there was protest, but they had no choice but to do it. There was not avenues of escape and running that they could get in urban areas. And now you see, and look at Guinea and Liberia, where you're talking 1/3 to 50% of the population lives in towns. And we're seeing in cities, and so we're seeing now the urbanization of the disease, which will be much more difficult to control. And look at the current results right now. This is the wrong shape of an epidemic curve. You expect, all the other outbreaks, once somebody got involved, you saw it come down and burn itself out with a little bit of effort. But we're talking about thousands of cases now and thousands of deaths that are spread all over this area. And I was going to put maps, but I was just getting too much. They're literally in cities and rural areas combined. Should you want to see it, here's the report from August of WHO trying to put some control in that, and people now have been flown in, and teams have been flown in. And the piece of that I think is important, that they just come right out and saying that how you stop travel, you essentially use quarantine, you keep these people, the only people that are allowed into the contacts are all put into some sort of follow-up in a quarantine, except for the healthcare workers that now can be trained how not to get it. And they're all, any person who is a probable case gets isolated into these facilities, and there's essentially no exit except to get healthy and go home. If that's not bad enough, I don't know if you saw the news today, but now we have a new outbreak in the Democratic Republic of Congo, just to the south of Sudan, with 24 new cases of Ebola on that side, with the same usual issue. You get a bushmeat hunter who the father brought it into the house, and the wife butchered the animal, and then she died, and a whole bunch of other people died. And then you get into the usual healthcare workers and funeral contacts, because they bathe the bodies in these funerals. In Sudan, you really have to step on tradition in this. One, you're isolating patients, and two, we did not allow funerals. We buried the bodies ourselves, which obviously is against all the tradition, and you can't get away with that in a lot of places. But that's what's, as the funerals were a major, the tradition of bathing the body was full of blood and virus, and so they would not, obviously, unless they dipped the whole thing in chlorine, they would get infected. So that's the story. You have this incredible belt of multiple diseases. This is yellow fever again, but it's the Ebola map from west to east that has the vectors and the environmental situation, both for the animals and for the humans that interact with the animals, and then for the healthcare system that cannot deal with the isolation of the patients. And so the disease goes on and on and on, and I think it will always go on and on. Everyone says, why can't we get a vaccine and a treatment? Well, you saw a little bit of the vaccine and treatment news on this. Unless there's a major investment to do this, it would not be an easy job. Maybe you can make a vaccine, but what's the market? What company is going to get involved in it? And even if you did have an Ebola vaccine, are you going to vaccinate all these people for a very low risk, or would you just vaccinate the healthcare workers? So it's a question that's always been left aside. So that's it. Let's open it up for questions now and see if... Yes. Oh, sorry, yes.
So my understanding is the West Africa disease actually might be less hemorrhagic and perhaps a less or a different type of...
The question, and the various strains, you saw those colors on the map. Those are the different strains of Ebola. And the question was, is there really that much difference in the clinical findings? And yes, some outbreaks have less, but is it really therapy or is it really the virus? And I don't know the answer to it because there's not enough, you don't have control situations where you have really good, if you had 100 people with really good therapy and you could see the difference. But, you know, a lot of these are true pest hospitals. I mean, they're left in there to be maybe fed, but not, not unless there's no Western type care that, for example, Ernie Bowen had in UK that saved him. And really hydration, IV hydration is all you can really give to these poor folks, unless there's a real treatment. So I don't know if the mortality differences are really significant. We'll just see. Yes?
With cold and influenza, you have a means of transmission through coughing and sneezing. Would a simultaneous infection of cold, flu, and Ebola provide a means of transmission of the disease through the air?
The question was, if you had somebody with a respiratory disease and coughing and Ebola, would you have aerosolized, could you aerosolize? I think it'd be highly unlikely, but I presume there's probably enough virus in all body. If you're having any kind of blood and you're coughing, you could probably spread some that way. But it's much more intimate usually. It would be unlikely. You got a question right next to him?
Does the virus remain active or able to infect somebody else and somebody who's recovered from it?
Yeah, well, that's actually a good question. The question was, what is the excretion of the virus from somebody who's recovered? And that's new information that we got with good virology once we isolated these people. For example, the doc who just recovered and was released out of the Atlanta facility, they excrete for weeks, especially in urine and such. So you have to be careful. I mean, so they don't release, at least the 2 people that have been quarantined in the United States are not released until they're virus negative. Yes?
Regarding the optics and logistics of quarantining people with temperatures, I imagine most people who in a high-risk zone with a high temperature don't have Ebola. Are they at higher risk of getting Ebola once quarantined, and how do you deal with it?
That's a very good question, and we were plagued with that question a lot. If your initial screening is going to be by temperature, do you throw them in quarantine just with a fever in a highly malaria endemic area? Because you'll end up infecting people clearly with Ebola if you do that, if there's really cross-contamination within the facility. One, you don't want to have cross-contamination in your quarantine facility, first of all. And 2, you really wait until you get a little bit more. They're at home, they're under surveillance, and you don't throw them into the jail until they really look like they have Ebola. Yes, in the back?
I think an interesting question now is trying to get a handle on the size and scope of how this epidemic will play out so that we can scale resources and response. The WHO this morning said they were anticipating 20,000 cases. Do you have any sense where that number came from or what that's based on?
The question was, there was a WHO statement that they're expecting 20,000 cases to come from this, and I have no idea where I'm sure they pulled that out of their backside, but someone probably mentioned that it could be as high as, I don't know where it came from, but, you know, the difference here is the fact that there's urban areas involved where people have pulled down quarantine facilities and pulled people out and that kind of stuff, where there's not the, essentially the cooperation that you have in a rural area. And so once it's in urban areas, I don't like the shape of that curve, obviously, at this late stage in the epidemic. So what it's going to look like in the end, I'm not going to predict, but it's going to get worse.
Initial modeling efforts have shown that the reproductive number is declining reasonably
Right.
they're getting, but not in Liberia, where it seems to be, for some of the reasons you mentioned, they've got much less control.
The question was that, or the observation was that the replicatory number looks like it's less than 1 in places, but not in Liberia. Now, all of that depends on good surveillance, which I think now will start. You know, now clearly lots of international folks going, and there'll be folks out there searching for cases to find out, because the repeated questions, both from people in the ministries and other observers, is that the numbers that I showed you were far underestimated, the total number of cases. So where they are and who's going to find them all, it's going to take an army of people. Yes?
Your graph had suggested that the outbreak started in April, but I believe there was actually an initial case back in January.
Yes, it goes way back. No, December, I think, was the...
December
Yeah,
2019,
well, yeah.
And it had a much more normal-looking epi curve.
Yeah.
It started to go down,
That,
and then it spiked
if
back
you notice, that epi curve didn't start. That was just and it keeps going to the left, small numbers of cases, and then this explosion now, yeah.
Can you speak at all about the control of the initial outbreak, or maybe policy, or the people who were dealing with it that led to its original decline and then its ascending?
The question, do I know anything about what was done there in terms of why it limped on and then exploded? And I don't know. I can only hypothesize that the control, as I mentioned, for example, in Zara, where this outbreak started, there was no control, and it stopped. It was only the one patient that went to the hospital that made it explode. And so if you, even in a rural area with minimal control, which is probably people learning after 1 or 2 generations they don't want to be around these patients, that it tends to burn out in a rural setting. But you get in this in the urban setting and urban hospitals, and the healthcare workers become the amplifier. And boy, it could really be, because then they're going to bring it home, and who knows where they're going to bring it. Yes?
Is there any evidence for genetic drift yet in the West Africa?
The question is, there evidence for genetic drift on this? And I don't know of any. I don't know how much. There'll be lots of genetic work on it. But the interesting thing is that this is 20 years, and it's been the same disease popping up over and over again. So at least in the animal host, it didn't seem to change much. Yes?
2 questions, or maybe 1. I'm a clinical physician, and I'm also a medical anthropologist, so I'm kind of coming from those perspectives. I was an advisor with the WHO on Ebola this summer and asked to go to Liberia, but due to other responsibilities, I couldn't go, and I was just looking through the emails and conversations. In talking about treatment and vaccine, it's troubling to me how quickly market comes up and that there's not a market for it, or who would pay for it, or where's, how does capitalism and money fit in? And I know that I'm asking an epidemiologist a question that's not exactly an epidemiological question, but I don't know how to think about this without asking the question of what are the other options? If developing a treatment or a vaccine could be helpful, but we're stopping thinking about it because there wouldn't be a market, and then we're not really thinking through the possibilities of developing that treatment for people who are dying, or vaccines for healthcare workers, et cetera, if they're the main kind of vectors in most of the outbreaks, then that seems very problematic to me. And what are the other options? What are the other possibilities?
The question here really dealt with the issue of seeing the market of this, that who's going to invest in either therapeutics or vaccines, given that this is a very impoverished area. And indeed, if you had a vaccine, how would you use it even? Because it is still a relatively unusual disease. And how do you drive that development so at least you have a vaccine? Well, it would seem logical to me from the government side that at least the laboratory workers dealing with this, which we use vaccines in laboratory workers very differently than we do the rest of the population, that spending the money to get an Ebola vaccine would seem to be an interesting and worthwhile pursuit. It is challenging, mind you, because how are you going to test the efficacy? You really have to go to primates and hope that works, and then put it into humans, recombinant protein presumably, and see if the serum of those people neutralized the virus just like it did in the primates. Not a huge job. And one would think that at least the military would be interested in having this. And I don't know that they haven't worked on it because they were the ones that had the laboratory capabilities to deal with a lot of this stuff. But it would seem wise that for the healthcare workers alone, that you could move in with an immunization about this time and work around the families, et cetera, et cetera. Wouldn't it be nice to have that tool right now? So I agree with you.
So for those healthcare workers who recovered from the illness, do you think they're protected against subsequent infection?
I think so. That's Lee's question, was were the healthcare workers protected? We certainly threw them back into the ward again, and none of them got disease. So that's a pretty good test, because this was not a great isolation facility. And so yes, I'm quite sure there's no second case of Ebola that I know about. And obviously these people had lots of contacts.
So have they looked at their blood serum from those patients to see if they're neutralized?
I don't know. The question was if they looked at their blood. Oh, sure. No, we had bloods from all of them. As a matter of fact, these folks were wonderful in that here they've just recovered from a god-awful disease, and we asked them if we could plasmapheresis them because we wanted their plasma for, if nothing else, passive immunity. And they were very nice to give us units of plasma, which, by the way, would lay them out in the heat there, and then you take a plastic bottle of blood and then just literally wait for it to, and then we had this pair of pliers-like thing to squeeze the plasma out one side and give them the red cells back again. And so it was about a 3-hour procedure to get a unit of plasma from these people. But fascinating in that part of the world. We kept all and brought it back to UK. It was, you would really have to do, the amount of parasites and other stuff in that material was huge. And so the question is what to do. How are you going to ensure that you may be protecting against Ebola for someone who's exposed, and God knows what else you're going to give them from this stuff. So as far as I know, that plasma is probably still sitting in Porton-Down and probably never been used. Yes?
How resilient the virus is outside of those, how long it can survive basically outside the body.
Oh, these are, really quite friable virus. There's, as far as I know, there's no surface contamination infection. So it would be an acute blood stick or spill. But these are, as you see, large envelope things. They're not going to last very long. I'm sure it's been done. I just don't know how long they last, but I'm sure it's very fragile. Yes?
I believe that there's effective, reliable diagnostics to confirm the infection, right?
Yeah, the question is about diagnostics. Are there? Yes, and there's very good diagnostics. Now, they're using high-end diagnostics, so it takes a few days to ship them. And so, but there should be very easy diagnostics in the field, for God's sakes.
And then they would use it to anyone who has fever, just to screen.
Well, the question was, could you use it for fever? For fever, you'd have to have PCR for the virus because they don't have antibody yet. So that's a little more complicated. And not to mention, you really want to find a way to get it cooked before you send it to PCR or send it to need, because that stuff's very, very infectious. So it would have to be, yeah, for early, an antigen at least. I mean, there's no reason you couldn't do an antigen test, but I just don't think there's one available. It should be. I mean, it goes back to your, why don't we have laboratory tests and therapeutics for a disease as serious as this? If not for using in the developing country, why don't we use it for our own labs? Yes? Yeah.
Could you use the horror of the disease to close down the bushmeat trade, or is it too popular?
The question is, can you use the horrors of the disease to cut down the bushmeat trade? I don't think so. I mean, this is just the way people live there. They're eating bushmeat all the time, and so, and how much is traded versus eaten themselves. I just don't think it's feasible. It's just going to happen, and the risk is low, obviously. But should you, drop all of your meat into Clorox before you eat it or something? I mean, at least cook it. I mean, but you don't have gloves and things to butcher. Look at our butchers.
Don, what's your your take on the idea of using already licensed drugs approved for other things such as lowering cholesterol to treat the immune response as a therapeutic measure?
Well, I haven't been keeping, the question was what about existing drugs for, that you can use therapeutically? And I only know of the two drugs that I've read in the press, that's all. Of one that the doc got before they went into isolation at CDC, and obviously they did very well. And that was all the drug that existed in the world, as I recall, from whatever manufacturer it was. But, it goes back to the issue of what's the...
I mean, the David Fenson hypothesis that you could use cholesterol-lowering drugs.
Oh,
to
no.
interfere with the immune
Yes,
response.
I don't know. That sounds, yes, I'm sorry I missed that, yes. I have no idea about the use of cholesterol-lowering drugs themselves for dealing with Ebola. It sounds nuts. Yes?
So, given where Ebola has just popped up in the DRC and the remoteness of the Equator province, do you think it's a safe assumption that it's a de novo case from the forest and not something that's spread from the outbreaks, the epidemics in West Africa? And if so, is there something you think can be said about the prevalence of Ebola in the animal populations?
The question was, when you see outbreaks like this, let's say now back in DRC, is this de novo or is it some importation via humans or other? And let me go back to the Sudan and Zaire outbreaks, which we assumed there was, 250 miles between those two, but I at least assumed that somebody had, the traders and someone had come in, and they're two totally different viruses. So I think a lot of these are spontaneous. These are viruses that get from the animal to humans and are, if you really could do sequencing on them, you find out they're probably different viruses. But because it just didn't make sense to have these connections between the two. So they're going to be, I'm sure they're going to be just another. Some of it is that, get all the press of, Ebola, then the next time a doctor sees a case with fever that's bleeding, instead of assuming yellow fever or something, will say, well, let's test for Ebola, and then you finally find another. I think that list of outbreaks I have no idea what the factor is of increasing number of outbreaks that really existed compared to those that were detected, but it's huge, I'm sure. Because these things, especially in rural areas, will dead end. And, there people die all the time. I mean, they get fevers and they die. And so maybe the healthcare system gets notified, maybe it doesn't. So I'm sure there's been lots of other outbreaks that didn't get into hospitals and the amplification system. But I'll bet these are two different. There's lots of bats peeing around across that area, and I'm sure there are going to be other separate outbreaks. Yes?
Are there technologies like nucleic acid-based tests available for the early diagnosis of this disease?
The question was, are there nucleic acid-based tests that are available to diagnose the disease? Yes, that's what's being used primarily. It would be nice if we would get the next step of having a simple blood test that you could use in the bush on filter paper or something that didn't require sophisticated labs. But all of these specimens are being shipped, which has an issue until itself, that you don't want to have the postman break the tube in the mail. I mean, but these are being shipped to capital cities where they have sophisticated labs now that can do it. Yes?
Hi, I'm curious about how quarantine policies have evolved as the disease moves to urban settings, especially in the wake of the current outbreak and some of the stories in the media about entire informal settlements being quarantined and patients or people who have been quarantined escaping and things like that going on, and people advocating for their rights within these populations. If you could talk more about that.
It's a very important question. Both the evolution and the reaction to quarantine. When you have an outbreak like that I just described in a rural, tribally oriented center where you've got tribal leaders that can keep things quiet and do what seems like logical approaches. It can be done in rural, tight societies in rural areas and around the world. When you get to the urban areas, if you see the breaking down of the quarantine that has been in the news, that it's going to be much more difficult, and that's what I was hinting to, that it's going to be stopping this by the, I mean, if I had to say what is the mode that the previous outbreaks have been stopped, I think the best term would be run away. You just, yes, you take some exposed people and take it out, but then they don't go anywhere. So they just, you end up isolating the outbreak by people disappearing from contact of infected people. Urban areas is totally different. You get in urban hospitals and urban societies where you see them tearing down the quarantine walls in cities in West Africa, and an epidemic curve that's shaped like that. And that's where you get these predictions of having many, many, many more cases. And I think there's some reality to that, because both in Liberia and in Sierra Leone, all the capital cities have had infected people now. And so you're getting a disease not in the rural bush, but in an urban, difficult to control society. It's a much greater risk. Yes?
Seeing as how the reservoir is potentially really large and, well, it's mobile, it can fly, is there anything that can be done to prevent future outbreaks?
That's a very good question. Given the reservoir infection is more than mobile, is there a way to prevent future outbreaks? And the answer, I think, is no, other than you know, I don't see teaching these people to stay away from the blood of animals and wear rubber gloves before they're cooked is just, it's a great idea, but I just can't see it happening because it's so prevalent in that part of the world. And I don't see the issue really is early diagnosis and isolation of the first 1 patient or 5 patients. And then that really works because you can see that it burns out by itself. We don't have to do very much isolation. It's once it gets into the urban hospital. The hospital is the source of this. I mean, it may come from bats, but it's hospitals that spread it ultimately, and hospital-like environments. And so what you want to do is diagnose it early, and that goes back to the issue of can we get diagnostics out and can you get systems out that diagnose it and indeed ultimately treatment. And this would be fun to do and trivial in terms of cost, to be honest. It's just that if your job in Geneva was to make a list of the most important diseases that you want to take care of around the world, Ebola would not be on your list. It causes great chaos and it causes financial hurts. And maybe with this one, you can see if it really starts exploding in cities, then there'll be some more interest in it. But up till now, it's been it's chaos, and it's tough on these areas, but it's still a relatively small problem compared to so many. I mean, would you rather treat diarrhea around the world, put money into diarrhea therapy or into Ebola? And it's clear what the answer is. Yes?
How do you figure out how fruit bats get Ebola in the first place? How do they get rabies? How do they infect other primates? They eat fruit.
That's a great question. Why do the fruit bats and other bats have rabies and Ebola and are happy with it? I have no idea. I don't know if it's vertical. If it's been in the family for so long, I've got to go bleed the baby fruit bats and see if they get it from their mothers.
Still a transmission to the primates, transmission to bushmeat.
Well, yes, there is, but I'll bet somebody is I mean, clearly, I'm sure if you talk about aerosol, not that truly aerosol, but the Nzara outbreak in the cotton factory, I'm sure those fruit bats are peeing on the cotton somewhere. And then this place was incredible cotton dust. I'm not sure it's aerosolized, but there's particulate virus that infected those half dozen people in that thing. And that was one of the real examples of a vector, or at least an airborne or dust-borne. It was a horrible cotton factory. I mean, you just couldn't breathe when it was working.
That's kind of strange because it doesn't fit very well with what we think about the length of life of the virus outside of.
Yeah, this was obviously fresh pea, yeah, and dried, and yeah. Now, but is it in the, was it the fruit bat or was it rats? I mean, was it some other animal that was peeing on the, and I don't know. Yeah.
So, Don, I'm going to ask you to make a prediction outside your expertise, but since you've been there, you're as good a person as any to ask. So what we have here is a very stark confrontation between biology and culture. So who's going to win? Because we have a vested interest in this, don't we? We have a vested interest in culture losing this war. So are we going to, is the rest of the WHO and the rest of us going to march in there and destroy culture, or are we going to allow this to fight itself out and see who wins?
The question was who's going to win here in terms of culture versus biological logic. And I think ultimately biological logic will, or the culture will beat the biology in terms of the spread. That this is so bad, and the disease is so bad, interestingly, that people will ultimately come to their senses. Now, I'm not worried about that ultimately. The question I have is that have we already passed that, where the spread within this facilities and such is so bad with a curve like that, this late in an epidemic. I mean, this has been going on for, what, since the first of the year, and still now we're starting to see it go this way. The question to me is not the social pressure to do something about it, because it gets immense when people are dying everywhere. But then you say, can you do something about it? And do you have the facilities to take care of it? And that'll be an interesting, I think you can, because it's terrifying, but it is doable, and people learn about it. But this is the first time it's affected these places, and they have very difficult public health structures and health structures. But the massive amount of resources going in hopefully will help. But I don't know when that thing is going to tip. I just don't know. Yes, I think last question, Art. Can we? Okay, yeah.
What are some of the travel precautions that are being taken inside of Africa domestically to ensure that it's not hopping from one country to another?
Yeah, the question is, what about travel precautions and indeed quarantine? And you'll see this going up and down because, yes, nobody can travel there and everyone can travel there. And I mean, it's fascinating how it usually is more disruptive than helpful, to be honest. I mean, when in our outbreak in southern Sudan, we were quarantined in. That's what they did. But nobody could. No traders were coming in. There was absolutely none. So I'm not sure it makes any sense, to be honest. Much of the stuff just gets made out of panic. And does it make sense? Well, fever surveillance. If you're coming out, you really want to know, did they have contact with somebody who was very sick? Other than that, there's no problem. But you ask that question of someone who indeed was in a house with an Ebola patient, they might say no. So these are much more difficult, very easy to make the rules, and much more difficult to make it effectively do anything, as much quarantine is. So I think we'll see these waves of severe and then relax and severe and relax for a while. But the best is surveillance, so you find out where the disease is, where the people are, and who move. But when you start getting it, I mean, you saw the pictures. That was not an urban area where I worked. I mean, that was as rural as you can get. I mean, there was some concrete houses in the middle of that, and then next to them were bushgrass that's right around. That's where people lived. So that's bush Africa. That's not downtown Monrovia, where you have a very different setting and much more difficult to contain.
Okay, Don, thanks very much.
Sure.